Hello everyone. Welcome to another Rafael Medina subspecialty virtual morning report. I'm Youssef. I'm one of the CP Solvers members. Very excited today to have many brilliant physicians from my institution, which is Emory. John was chief resident when I was an intern, and he was one of the best chief residents we've ever had in terms of education, and he was going into infectious disease but knew medicine in every single domain and impressed us with every single domain, and it's truly impressive to everyone who meets. He won a fellowship teaching award just like a month ago. So if you want to introduce yourself, John, tell people why they should go into ID, and tell us about yourself.
Thank you so much, Yusuf. That was such a kind introduction. All right, welcome everyone. My name is John Huang. I'm one of the now second year ID fellows over at Emory. And why I went into infectious disease throughout all of internal medicine residency, just absolutely loved general internal medicine and naturally gravitated towards ID because it really involved all systems. It didn't focus on one specific organ or any specific process. So really loved all of the kind of systems interactions that came with ID. And I also really loved doing like being a diagnostician, like really diving into all of the exposure histories, all the exotic, animal exposure, sexual history. I really enjoyed piecing all of that together to put it into the whole complete like patient presentation. And also more so during fellowship, I really enjoyed like the multidisciplinary portion of it, where we get to interact with surgeons, ID pharmacists, really everyone across the healthcare system, particularly in a stewardship role. And so that's what I'm particularly interested in, potentially transplant stewardship. So thank you again all for joining.
Yeah, thank you, John. Millie is also one of our superstar residents who is also going into infectious disease. Millie, do you want to also introduce yourself and tell them something about you?
Hi, everybody. I'm Millie. I'm a newly minted PGY3 here at Emory and happily going into ID. I think me and John actually have similar loves of why I love ID, but I think more than anything, it's kind of like attracts like for me. I found myself amongst the same group of people who love to kind of dig into a problem and explore it from all the different angles, and commonly love coming to things that maybe we don't know what's going on. It's always been a favorite area of mine and a favorite group of people to kind of discuss with. And so I'm excited to hopefully join the area next year and excited to be here.
100% agree, Millie. 100% agree. And lastly, Varun Phadke is, I've said this before, the role model for every single person I've met at Emory, and it's literally the one of the best educators that I've ever met. Varun, do you want to also introduce yourself and tell people why they should go into ID?
Yeah, of course, Yusuf. Thank you for having me back, and I'm very excited to be here. I mean, in addition to getting to work with super enthusiastic, kind, brilliant people like Millie and John, I think one of the other reasons I gravitated towards ID beyond the things they said is we get to go everywhere in the hospital. I remember when I was on my ID rotation as a student and then as a resident. I'd always get my steps in, right? We go to radiology, we go to microbiology, we go to the ER, the ICU, every floor in the hospital, surgical floor, medicine floor, OBGYN, we're everywhere. And I loved interacting with all those different people and learning from them and hearing their perspective on challenging cases. So that's what brought me to ID.
I I agree. That was my impression as well when I was on the ID rotation. We would literally go to places in the hospital I've never been, and that was amazing. Uh, if y'all are ready, Millie, we can start with the first aliquot in the case.
That sounds great. So I'm going to introduce you to a 62-year-old gentleman, and he came into the hospital with a 1-week history of a productive cough. This gentleman is from the Atlanta area. He had a history of coronary artery disease, and he had a CABG back in 2023. He also had a mixed diabetic and hypertensive nephropathy that ultimately led to a living unrelated renal transplant in 2013. And very recently, a month prior to his admission, he was in the hospital for Citrobacter coteri bacteremia. And he came in with a 1-week history of shortness of breath with a productive cough. and a new lesion on his forehead. The lesion had popped up as like a blister, and then popped in the shower one day and drained what he thought to be was like a clear fluid, but he couldn't remember if maybe it was darker or it had pus because it kind of ran with the water. It never hurt, it never itched. And he actually had a similar one pop up closer to the hospital day of admission. He went to an outside urgent care facility for the cough and the congestion, less so the forehead. He just kind of thought he'd bumped his head. And at that time, he had a fever of 100.9. And so they sent him home with a Z-Pack. They sent him home with a azithromycin for 5 days. And he was also having some ear pain at the time, so they gave him some ear drops. And they said, go to your primary care doctor in a few days and follow up. He visited his primary care doctor 5 days later, and he was still having symptoms. So his primary care doctor added ceftriaxone, or they added cephalosporin to treat him for a broader community-acquired pneumonia. But ultimately, 24 hours later, he just felt so atrocious that he came into the hospital.
Thank you, Millies. Is that the end of the first ad quote?
It is.
Okay. John, I'm gonna direct the question to you first. We have a lot of information, so we see like a rash on the forehead, some shortness of breath, some cough, and some antibiotics here and there. So how are you like thinking about this, and how are you synthesizing the information, and how will you decide which parts do you work up in general when you're seeing this patient?
Yeah, absolutely. Thank you for all of that information, Millie. Definitely a lot to digest. I think starting out, we have that one-liner for the patient, and the things that really particularly stood out to me is whenever I think of a new patient, thinking of the degree of immunosuppression, which really helps to organize my differential. And so we have a 62-year-old gentleman that has a history of a fairly recent renal transplant. I think within the past year was my understanding. And so certainly renal transplant, being on immunosuppressives chronically, will predispose them to a lot of conditions that we don't typically see in our immunocompetent hosts. The other kind of piece of information that really stood out is kind of the acuity of this situation. This is a 1 week history of reproductive cough. And so that kind of lands us right between more of an acute versus subacute presentation, which kind of helps us also stratify and to think through our differential as well, thinking this isn't necessarily just an acute presentation, just a couple days. Rather, it seems to be going over the time period of about a week. Other things kind of on review systems that really stood out to me is pulmonary symptoms with, productive cough, as well as some kind of skin changes. And so thinking of a syndrome that's kind of involves both the pulmonary system as well as a skin presentation is fairly unique and has a broad differential, but helps us certainly help focus our differential. And similarly, other things kind of relevant from the HPI, it seems like he had some contact with the healthcare system where they gave him pretty appropriate antibiotics for community-acquired pneumonia, starting with azithromycin and then broadening to ceftriaxone, a third-generation cephalosporin, along with azithromycin. And so it seems like he had some pretty adequate community-acquired pneumonia coverage, but despite that had progression of symptoms. And so as I'm kind of thinking through all of this all together, kind of a pulmonary syndrome involving the skin, that seems subacute in nature over the course of a week in a patient that's immunocompromised with a renal transplant. We don't quite know all of his immunosuppression. We also don't quite know any of his social history in terms of exposures or encounters. But those are all kind of things that I'm thinking about. And then kind of the other recent healthcare exposures, he was treated with community-acquired pneumonia treatment, which is adequate with, typical bacterial coverage with a cephalosporin, as well as azithromycin for, atypical coverage. And despite all of that treatment, seems to have progression. So those are kind of the things that stand out for me. And I'm happy to dive into a differential, but I kind of wanted to start there, and then we can talk about differentials moving forward.
No, that's very, very helpful. And I think Millie will give us more information about the immunosuppression shortly, and that way we can dissect it further. Varun, anything you would add at this juncture?
Thanks, Yusuf. Yeah, no, I mean, that was a fantastic breakdown of this first aliquot. I have very little to add to what John said. I mean, I agree that I think a big sort of influencing variable in our evaluation of this patient is the fact that he is immunocompromised. And I think characterizing both the nature and the severity of the immune deficit is really key. And we know from our kidney transplant population or organ transplant population that those patients are on medicines to suppress T cell function specifically. And so that makes us think of or prioritize certain pathogens over others. And it would be sort of helpful in the next few aliquots to pay close attention to the sort of if the patient has been treated for rejection or has had their immunosuppression augmented or altered in any way that might make us invoke other arms of the immune system that are also weak, that might make us invoke other pathogens. And then the only other thing I'll add is I think in any immunocompromised host, we often are less willing to ascribe every element of their presentation to a unifying diagnosis. And though we would like, obviously, to have a single explanation for both the skin and the lung lesions or pulmonary findings, I think we'd want to make sure that there aren't more than one diagnosis at play.
Perfect. Thank you, Varun. Back to you, Millie.
Sounds good. So from the remaining kind of social history and medicines history, he had no allergies that he could report. From a medication perspective, he was on a multi antihypertensive regimen, including an ARB and a beta blocker and a calcium channel blocker. From an immunosuppression standpoint, he was on tacrolimus, 1 milligram BID. He was actually on sirolimus as well, 2 milligrams daily. And then he was taking prednisone 2.5 milligrams daily. And then he was on a diabetes regimen with some oral medications, but not on insulin. From a surgical history, the transplant, John, was in 2023 to October of 2023. And he also had his gallbladder removed in 2015, and he had a cabbage back in 2023 as well. He also had an aortic valve replacement alongside his cabbage at the same time. I put my ID hat on when I took his HPI, and I tried to get a really robust social. He was a former teacher. He had a wife, he had a dog, he had kids, but he seemed given all the chronic medical history that he had accumulated, he really didn't have any history of travel or outside of the general Atlanta area. He'd never been to prison. He didn't have any high-risk sexual exposures. He had never used drugs. He denied using tobacco. And generally, he said he's been mostly in and out of the hospital for the last few years of his life, and mostly Atlanta bound. And then from a family history perspective, dad had hypertension and had a stroke, and mom had diabetes. Neither of them had had any transplant history that he knew about.
Thank you, Millie. John, ask and you shall receive. In terms of immunosuppression, we see here that the patient is on tacrolimus, sirolimus, and prednisone. How would you want learners to describe the immunosuppression in this case, for example, or if they're presenting the case, how would you want them to think about the immunosuppression in this case?
Yeah, absolutely. So I think the key pieces of information whenever I hear kind of a transplant presentation is knowing when the transplant happened, first off. So recognizing that it was October 2023 was very helpful. And then also kind of knowing the pre-transplant factors that led them to need the transplant. So what indication they had for needing the transplant, in this case, hypertensive nephropathy, but kind of knowing their general landscape of their medical issues and why they needed that transplant to begin with helps me to envision this patient pre-transplant. And then when we're talking about the immunosuppression, it's helpful to know all of the different medications. This is a very kind of typical immunosuppressive regimen for a renal transplant patient, tacro, sirolimus, as well as prednisone. And sometimes it's also helpful to know what conditioning regimen patients receive, because that also changes some of their complications. So what initial immunosuppressions they received at the time of their transplant. and all of those kind of different pieces of information, and in particular also like post-transplant complications. Do they have a prolonged hospitalization for some kind of hospital-acquired infection, or if they've had issues with rejection or other complications associated with their transplant. So I kind of think of pre-transplant factors, so why they needed the transplant, when they received the transplant. I think of post-transplant problems, so any complications they develop, such as rejection. And then also just knowing if they've had increases or decreases in kind of the dose of their immunosuppression are ways that I kind of frame my differential when I'm approaching transplant patients.
Thank you. That's very, very helpful. I know we're going to get more information shortly. And Varun, anything you would add at this juncture as well?
I think John has described, I think, our approach to immunosuppression really well, and I don't think that there's a lot of exciting social history to inform our differential at this point. I think one lesson that I'll pull out here, or pearl, that all of us sort of engage in all the time, is how much inference we make from the way people have been treated in the past for any condition, and it gives us a lot of insight into their chronic medical condition. So for example, when you hear that a patient has hypertension and then you hear their medication regimen is like 4 antihypertensive medications, you instantly make judgments about the control of their blood pressure or how severe their blood pressure is. And I encourage everyone on my team to make similar inferences about someone's sort of history after their transplant based on what immunosuppressive regimen they're on, because each institution has a specific regimen that they like to use. And anytime the patient is on a regimen that is slightly different than what your nephrologist or hepatologist or whatever are used to using, sort of makes you wonder what happened to this patient that made them deviate from their usual protocol. So I saw a comment in the chat about the patient not being on a medicine like mycophenolate, which often is in the first line regimen of post-transplant immunosuppression. So it makes you wonder, is there a reason this patient was taken off of mycophenolate, like a side effect, like a gastrointestinal toxicity, or another opportunistic infection for which the patient had their MMF discontinued? And maybe we'll find out more about that. Maybe we won't find out more about that, but you can start to make some inferences just based on what medicine the patient is now on and theoretically could have been on.
Thank you. I love how you try to find out infections or infections that might not have mentioned just by asking about the immunosuppressive regimen. So that's good to learn. Millie, I don't know if we're going to learn about the mycophenolate, but back to you.
I don't remember. We're going to find out. But my next aliquot is his exam. So he presented to the hospital afebrile. He was tachycardic in the low 100s, breathing around 20 a minute, but blood pressure was 130/67. And his oxygen on presentation was 87%. And with the addition of nasal cannula up at 4 liters, he increased to 96%. He was very tired appearing. He could answer questions, but clearly very ill appearing, almost acutely, a little bit on top of chronically. That forehead lesion that he had had like a scab, and I couldn't detect any sort of pus or express any sort of drainage or any sort of surrounding swelling. The scab kind of encompassed the entire lesion on the forehead. Again, from a neurological perspective, fatigued, but he was alert, he was oriented, he knew where he was, he could appropriately answer my questions, and he could follow all the commands. And from a symmetric standpoint, he was symmetric in both his motor and his sensory modalities. Cardiovascular, besides being tachycardic, I heard no murmurs. He had intact pulses. He was perfusing bilaterally. His work of breathing, once on 4 liters of nasal cannula, was actually quite relaxed, quite normal. His respiratory rate dropped down into the 15s. He had bilaterally diminished lung sounds, but no wheezes. And I also couldn't hear any crackles or rhonchi either. The belly was also benign. There was no issues. And then he had some mild pitting edema up to the shins, which he said was not normal for him. And a joint, head-to-toe joint exam was completely normal.
I added the picture of the lesion. I can enlarge it shortly. And John, I was going to ask you, like, what would you infer for this from this patient from this exam? And is your threshold to consider imaging lower in patients who are immunocompromised? And is are you immediately going to image, like, is it going to get like a pan scan, for example, in this case, or how? What is your thresholds? How do your thresholds change with immunosuppression in general?
Yeah, absolutely. So first off, the things that jump out to me from the vitals and exam, the tachycardia, normal blood pressure, no fevers, and the hypoxemia really stand out to me. So the patient is tachycardic and hypoxemic, generally appears ill. And I appreciate that you guys have the picture kind of centered in there as well. That's really helpful to actually see and visualize the image itself. It's always helpful to kind of qualify and describe as much derm terminology as possible. And I know kind of from the medicine side, it's difficult to describe rashes and lesions particularly well. But from the photo, it looks like fairly ulcerative potentially. I'm not seeing kind of a raised lesion. It doesn't seem particularly well circumscribed and kind of ragged edges. So it seems more of, from what I can interpret, more of an ulcerative lesion without any surrounding erythema or drainage. And then the other things that were kind of notable being like the mild left lower extremity edema, which seems atypical for him. The rest of the exam, the pulmonary exam, seems fairly unremarkable, nothing else really focal on exam. And to your second point about imaging with immunosuppression, I find imaging particularly of the lungs in someone that has hypoxemia and lung complaints in someone that's immunosuppressed really helps us to kind of stratify and develop our differential. There's so much that we can really interpret from the distribution, from the localization, if it's ground glass, if it's consolidative, if it's cavitary, if it seems to fit a vascular distribution to suggest some kind of endovascular infection. So I feel like that really helps us on the ID side to help develop our differential by having imaging. And so my general approach is in patients, particularly with immunosuppression, with objective findings of like hypoxemia, I have a very low threshold, at least for CT chest without contrast, because there's so much we can glean in terms of localizing where it involves, characterizing the lesions that we see on chest imaging, particularly like ground glass versus consolidative versus nodular versus cavitary lesions. And so I think CT chest without contrast can add so much for a pulmonary evaluation in an immunosuppressed patient.
And is there anything else that you would want at this juncture? Like, what would you order if you were seeing this patient right now, for example?
Yeah, so I think this kind of gets into a little bit of our differential. And so I try to holistically combine all of try to find a unifying diagnosis for both the skin lesion and pulmonary findings. And so the buckets that I think are most helpful once we kind of qualify the syndrome, where we're trying to find a pulmonary skin syndrome, is thinking through kind of the microbiology between like bacteria, atypical bacteria, viral, fungal, and then parasites, et cetera. And so thinking kind of through my differential in this situation of someone that has a renal transplant, subacute cough with a skin lesion, thinking through these different buckets of bacterial, there's not that many things that can cause unifying diagnoses, but considering he has hypoxemia and predominantly pulmonary complaints, just thinking through your typical bacteria, strep pneumo, H flu, your typical pathogens that could cause community-acquired pneumonia, Moraxella, which those typically don't also cause a concomitant skin finding. So those would be kind of lower on my differential. Similarly, atypical pathogens that can cause community-acquired pneumonia, the Legionella, the Mycoplasma, those kind of things also typically don't have pulmonary findings. But thinking through, subacute shortness of breath, your atypical pathogens. And then also similarly thinking of other atypical bacterial pathogens, things like nocardia or actinomyces can have manifestations within the lungs like cavitary lesions, but also can occasionally have skin findings as well. So those are kind of the atypical pathogens, nocardia, actinomyces that I might be thinking about also. Viral would be a little less likely. Typically, when we think of like viral presentations of pulmonary manifestations, they tend to be pretty sick. And we usually think of like patients requiring like ICU, like if they have HSV, CMV, or EVV, like pneumonitis, those patients tend to be very acute, very sick presentation from the get-go. And so overall viral infections may be a little less likely in my mind for this kind of more subacute presentation. I think a big bucket that I would definitely want to focus on is also fungal infections. Fungal infection, particularly in immunosuppressed patients. You can have fungal pneumonias and also have fungal skin manifestations. So stuff like cryptococcus, aspergillosis, those things can have both pulmonary skin manifestations. Some of the rarer molds can also be implicated. Mucor, some of the dermatiaceous molds. So I think something that really draws my attention whenever I think of pulmonary and skin manifestations is fungal etiologies. And then the less likely, no clear exposures, but mycobacterial infections certainly. So TB, any of the non-tuberculous mycobacterium can have pulmonary skin manifestations, and then some of the parasites. None readily come to mind in his particular case, but just making sure we have a complete differential, considering certain parasitic organisms. And so that was a long, rambling kind of differential. But to answer your point about what I would consider doing next, I certainly want some lung imaging, which will help us kind of stratify as this cavitary, consolidative, nodular ground glass. So CT chest without contrast. I think I would start with some of those pulmonary non-invasive, like try to get a respiratory culture if the patient's able to produce sputum. I would consider getting, like urine Legionella, potentially, depending on your institution, like a respiratory biofire panel, which is like a multiplex PCR that they can run on sputum to evaluate for a whole host of different types of bacteria, viruses, et cetera. And then I would also consult our derm colleagues. Our derm colleagues are fantastic resources. They can biopsy lesions. Tissue is often the issue, and I would love to get a sample of that, the ulcerative lesion, to send for pathology and also for cultures, because I think there's a lot to glean from that and getting their expertise. That's one of my favorite parts of ID, is being able to discuss all these cases with some wonderful experts. So I would definitely have dermatology also take a look. And also I would add on some fungal non-invasive testing, for instance, like galactomannan, potentially for aspergillosis, maybe a beta-D-glucan, and then a serum cryptococcal antigen is a good like non-invasive start to kind of evaluate some of these etiologies.
John, that was an expert discussion. So thank you, Varun. Anything you would add to that?
No, it's really hard to add anything to that, Yusuf. So what I'll say is I think I'll just put in a plug right now for Transplant ID because I think one of the fun things about Transplant ID is that you get to do this sort of intersecting schema that John has articulated of, what infections can this patient get based on their immune system and plus minus their prophylaxis regimen, if they're on any. And then what infections make you sick in the pattern that you're seeing in the patient, right? So as John sort of highlighted, this patient's pretty acutely ill, right? They're hypoxic, tachycardic, and that, in our minds, already begins to limit a little bit the list of pathogens that could do that. And then if you go back to what pathogens is this patient at risk for, given that they're on tacrolimus and sirolimus and prednisone, we're usually thinking about intracellular pathogens controlled by T cells like viruses, intracellular fungi, intracellular bacteria. And most of those are usually subacute illnesses, with the exception of viruses. And so that kind of puts us in a kind of unusual bucket for this case. This is an acute illness occurring in a patient with a cell-mediated immune deficit, who then has a simultaneous lung-skin syndrome. So I think I wouldn't do anything different than what John outlined, which was really nice. I think one virus that I will mention is, only because I didn't see him on any prophylaxis, is varicella zoster virus, which can cause ulcerative skin lesions and pretty profound pneumonia in the right host, or I guess the wrong host. Though the fact that this patient's lesions are totally not painful or itchy would be somewhat unusual, but I wouldn't add anything else to the differential at this point.
Thank you, Varun. And I know now there's like the cell-free DNA testing or the carriers testing. Is there a role for that here, or is that more like last ditch after we did the first workup, we can't find out, and then we would send it?
Yeah, I can start with my opinion. I would also love to hear Varun's opinion. We have a lot of new technologies available, including Carius, as you referenced, which is the company that does that testing, taking a sample of serum, and they are able to run a whole host of different PCR amplifications to try to find pathogens from the blood. So Carius, for the most part, is a blood-based pathogen screening. This is in contrast to like broad range PCR, which we often will do on tissue samples, CSF samples. And so one is from the serum and the other one is typically from a tissue or CSF sample, for instance. Usually we would try some of these initial diagnostics first, unless we're truly like scratching our heads, really perplexed, and we don't really have any answers from initial testing. Have been situations where I have, in discussion with my attending, have pulled the trigger on some of these more nuanced PCR screenings. I think what makes it difficult is always interpreting these different testing, in the sense that it's hard to tell if it's a commensal organism, if it's truly pathogenic. And so sometimes you'll pick up a host of targets, including like anaerobes, and not fully know how to interpret all of those studies. And so usually I prefer doing some initial testing, screening. If we're really scratching our heads and or the patient is not improving, then there's the whole discussion about pursuing the Carius testing, which is again from serum, versus broad range PCR 16S, 18S, which tries to amplify bacterial or fungal targets.
Yeah, I wouldn't add anything to what John described. One thing I will say is that it's very institution dependent, Yusuf, to your question. There are some institutions that send a lot of cell-free DNA assays and therefore have accumulated this, meaningful experience interpreting both false positives and false negatives. Our institution historically has not sent a lot of that test, and we are, as a result, sort of wary about weird results that might come back and having to interpret them on the back end. So I would say that it's a little bit institution dependent. And in a case like this, I think we would, in our center, favor pathogen directed testing first, and then turn to that pathogen agnostic testing as a sort of last resort.
Thank you both so much. Back to you, Millie.
Sounds good. So aliquot4 will be some of our basic labs and basic imaging. For his CBC, his white count was 9.4. His hemoglobin was 9.2 with an MCV of 79. His platelet count was 209. On his CMP, his sodium was 123. His potassium was 4.2. Chloride was 94. Bicarb was 15. Creatinine was 4.4 with a BUN of 87. Glucose was 427. Calcium was 9. Total protein was 6.3. Total bilirubin was 1.2. His alk phos was 243. His AST was 22. His ALT was 13, and his anion gap was 14 calculated. A couple of other lab tests that were thrown at the beginning. He had a BMP that was 967. His ferritin was 901.2. And he had an elevated procalcitonin, although I did not write down that level. And then a couple of initial studies or imaging that was done during the first 24 hours, aka when he was in the emergency room. He got a chest X-ray, which was read as worsened interstitial pulmonary airways with hazy, patchy, and nodular pulmonary opacities. And a follow-up CT chest had innumerable pulmonary nodules with mediastinal and hilar lymphadenopathy, and a noted but stable right pleural effusion compared to a study when he was hospitalized a month ago of the same size. And then they also scanned his abdomen and pelvis, and he had rectal thickening, which was also stable from imaging done a month prior, and non-obstructive stones in his transplanted kidney.
Thank you, Millie. John, I also wanted just to take your thoughts about how does this change your differential diagnosis, and does this narrow it down further?
Yeah, absolutely. From the initial, hematology chemistry panel, not any particular labs that kind of deviate my differential. I think the white count 9.4 is not particularly remarkable. Platelets of 209 also does not seem to have any evidence of, DIC, no pancytopenia, nothing is really kind of standing out from a hematology standpoint. And then chemistry-wise, sodium 123, hyponatremic, we classically associate that with Legionella and certain other, some pulmonary pathogens, but nothing in particular from the chemistry. The glucose of 400 is a bit surprising, and someone that I don't see has like a history of diabetes per se, but elevated glucose, anion gap of 14, nothing else particularly stands out from the chemistry. I think what really is notable is the chest imaging, the chest X-ray and CT chest, showing the innumerable pulmonary nodules and mediastinal hilar adenopathy, as well as the stable right of fusion. I think whenever I see a CT chest, and I love to pick the brain of all of my chest radiology colleagues and friends, it's very helpful because that helps to stratify and really adjust our differential. Whenever I think and see pulmonary nodules, an immediate thought is something along the lines of more fungal or mycobacterial in origin. And then when we combine that with evidence of lymphadenopathy, I think that also really bumps up the kind of more fungal versus mycobacterial causes, and maybe less likely do we see with bacterial, atypical bacterial pathogens. Sometimes we encounter this with like endovascular infections. He's certainly at risk in the setting of the Citrobacter, bacteremia. He has, I believe, a history of aortic valve replacement, and certainly could have something, potentially, theoretically, have endocarditis. Although with aortic valve replacement, if we are saying this is a prosthetic valve, it would not typically cause septic emboli to the pulmonary system. And so he certainly has risk factors for like an endovascular bacterial process. But really with that CT chest, with the pulmonary nodules and lymphadenopathy, really bumps up the fungal versus mycobacterial pathogens in my mind. And I saw in some of the chats other people mentioning the endemic fungi as well, which I didn't really include with my initial differential, but certainly with some kind of pulmonary skin manifestation, something like histoplasmosis, blasto, are also things that I would include on my differential, and consider ordering something very easy and non-invasive like a urine histoplasma antigen, which can also have some cross-reactivity with blasto. And so it really just bumps up more of the fungal mycobacterial, and potentially, depending on his risk factors, which doesn't sound like he has particular TB risk factors, but for completeness sake, you may also consider doing a TB evaluation with, AFB sputums, MTB PCR, which I know is always difficult for primary teams to manage, but we very much appreciate when everyone's able to cooperate together to complete these TB rollouts.
Always happy to do the best thing for our patients, Varun, what would you add?
I'll start by adding that this patient has a lot going on. So from an infectious disease perspective, I think we prioritize thinking about what diagnoses the CT scan leads us to, as John has very nicely outlined, thinking primarily about fungal infections and mycobacterial infections. I hesitate to sort of get any more specific than that, because I think anytime I have tried to attach a specific illness script to an immunocompromised patient, I have been humbled by the ways that patients can present differently than what I was expecting them to. I think many people in the chat have pointed out pathogens that can cause skin and lung disease that could manifest like this, including the endemic fungi, as John highlighted. Specifically, both histo and blasto can have skin lesions that appear like that. From what I can tell, based on the history you gave us, I don't think this patient was at risk of coccidioidomycosis, but That said, in our organ transplant recipients, one has to wonder about the possibility of donor-derived infection, though this would be sort of pretty far out for that entity to be manifesting now, based on what you told us about the time of transplantation. The only other thing I was going to mention was there's this rectal thickening. I don't know if that's a total red herring. If you're trying to invoke a pathogen that involves potentially the GI tract, the pulmonary system, and the skin, again, thinking about atypical mycobacteria like Mycobacterium avium or fungal diseases like histoplasma. But again, we tried not to read too much into the abnormalities to identify a unifying diagnosis, because these patients can have as many diagnoses as they want.
And lastly, what would you want to order right now, or what would you recommend the team order right now?
Yeah, I think everything that I kind of mentioned previously that was already nicely highlighted here under the other tests. I think definitely discussing with our dermatology colleagues to get a biopsy of that skin lesion to send off for pathologies, certain stains, cultures, would be fantastic. Potentially also, if discussing with our our IP colleagues, interventional pulmonology, if they could consider doing a bronch, trying to get us additional samples if there's any particular lesion, or potentially doing a biopsy of the lymphadenopathy. So I think prioritizing kind of the non-invasive testing that we have outlined, you know, the respiratory biofire sputum sample, potentially AFB sputum samples as well, Legionella, galactomannan, beta-D-glucan, then the urine histoplasma antigen, and then the serum cryptococcal antigen. And then also kind of discussing more invasively, talking to our dermatology colleagues for a biopsy, and or the pulmonary colleagues to see if we can potentially do a biopsy or a bronch to take some samples from within the lung. And we'll see what that initial testing shows.
Millie, back to you.
John, ask and you shall receive. They did a very robust workup on admission, so it will hopefully give you all of the answers you look for. So he, from a microbiology perspective, a pneumonia pathogen panel was sent and was negative for any viral and bacterial pathogens. He had a UA, which had 3 WBCs, trace ketones, but no bacteria. They did blood cultures, which many, many days after it had no bacterial or fungal growth. They started with a superficial culture of the forehead lesion, which only grew normal skin flora, but there was no expressible pus to it, and they did not unroof it at that time. They also sent a number of serum testing. They sent PJP PCR, CMV, BK, EBV, beta-D-glucan, and those were all negative. And then they kind of went one step further, and they did a bronchoscopy, and they collected bacterial and viral and AFB cultures from both the bronch as well as sputums. And those were all negative, including the PJP PCR off of both the serum and the bronch. And then to Dr. Phadke's point about institutional preference, this patient spent 24 hours outside of our institution before arrival, and had an infectious disease team that ordered a Carius PCR on day 1. So that PCR sample returned the Cotteri Citrobacter Cotteri very early on, but I will so it kind of came back like within the first few days before, and that was the information I had when he arrived at our institution. Yeah.
That sounds good, Millie. And the next aliquot will reveal the diagnosis, is that right?
Yes.
Okay. So, John, just any like closing thoughts, any other thoughts that from the information that we have so far, and yeah.
Yeah, just a quick clarifying question. With the Carius PCR, was he treated for the Citrobacter?
He was.
Carius? Okay. What was he
Yeah.
treated with? Just out of curiosity.
I will have to double check. I'll get you an answer.
Okay. And do we have results for like urine histo and some of those other?
Urine histo is negative.
Urine histo was negative. Okay. Something that I think is a nice teaching point that I often instruct trainees about is the difference between blood culture versus a fungal blood culture, kind of just going on a random tangent. Some people are very confused and will order fungal blood cultures trying to look for, Candida and some of those basic organisms. In reality, Candida and certain mostly Candida, but certain yeast can grow in a routine blood culture. The only time we really order fungal blood cultures, which I don't know if it was ordered for this patient or not, but fungal blood cultures undergo a process of centrifugation where they are really good at isolating intracellular organisms. And so we order the fungal blood cultures specifically for like endemic fungal mycoses that we're concerned for dissemination in the blood. Routine blood cultures are actually great at culturing Candida. And so no need to order fungal blood cultures if you're just tracking like candidemia. Those are really just exclusively ordered for more intracellular organisms. For example, endemic fungal mycoses that you're concerned for dissemination. That was a complete tangent, unrelated to kind of interpretation of what has come back so far, which is largely everything has been negative from everything that we've reported. Certainly, like all of the cultures would be helpful if something grew, but again, some of these tests don't have the best like negative predictive value. In that if it's negative, it's not sufficient enough to rule out for instance, like beta D glucan, if it's negative, it doesn't fully necessarily rule out fungal pathogens. And so I'm curious what the derm path and other invasive testing, what pathology reviewed the slides, if they showed anything remarkable. Sometimes we have a lot of difficulty culturing out certain organisms like fungus and mycobacterium. But if a skilled pathologist reviews the slide, sometimes they can see evidence of AFB organisms, they can see evidence of atypical bacterial pathogens. And so in usual ID fashion, I would pay a trip to our pathology colleagues and try to review some of the slides to see if they see any identifiable organisms that we weren't able to culture out. And there's certainly subsets of organisms that we just have difficulty culturing out. For instance, things like more atypical bacterial pathogens like Brucella, actino or nocardia are all organisms that we notoriously have difficulty culturing out with our usual culture media. And so I think having a discussion with our pathologist and reviewing some of the different slides and samples that we've been able to collect, I think would be kind of my next step before I start thinking outside the box in terms of other diagnostics.
I love that you demonstrated Varun's point that you go to everywhere in the hospital, with no exception, including the pathology lab, to look at the microscope. Varun, what would you add to that, and any closing thoughts before we hand over the diagnosis?
Yeah, I don't really have a lot to add to what John said. I think one teaching pearl that I'll add here is, when you have a sick patient, you try to gather as much information as you can based on the fastest tests that are going to come back. And unfortunately, in ID, sometimes the best tests are the slowest tests, like the cultures. And so we often have to use sort of surrogate tests to make diagnoses of these more difficult to culture organisms. And so, antigen tests, antibody tests, PCR-based tests, and a lot of those tests are actually done in-house at many hospitals. So a lot of the tests, for example, that Millie listed are actually like send-out tests at most facilities. So like the urine histoplasma antigen is a send-out test in most hospitals. And in contrast that with something like the serum cryptococcal antigen, which comes back usually very quickly because most hospitals have to do it in-house. And it's a real-time test at many microbiology labs where if you order the test, as soon as it gets to the lab, the microbiology technologist is required to perform it within a certain amount of time. And so you actually get the result in real time, like maybe even overnight, which can be relevant because it can change your management of the patient from either no antifungal therapy or antifungal therapy directed against Candida to antifungal therapy directed against disseminated cryptococcosis. So I only say that not because, I do know that cryptococcal antigen is not one of the tests that is listed there, but maybe I just didn't hear it. But I think as a general teaching point, I often sort of go through the exercise with my teams about which tests can we get you know, in a day, in a week, in a month, and which one, you know, is going to make you cross your threshold for doing something about it empirically.
Thank you so much. Millie, please tell us what happened.
Sure. And I will give gifts to both John and Varun. John, he was treated with 14 days of IV Rocephin for his Citrobacter a month prior. And then just to answer both the chat and Varun's original supposition, from a mycophenolate perspective, very early on post-transplant, he was on mycophenolate and had a lot of GI side effects. And per patient preference, they decreased it. And ultimately, he expressed a desire to completely go off of it and try alternative immunosuppression. And then from a cryptococcal, I was not withheld. It was ultimately negative. It was done at our facility, but it was not in the initial aliquot. But this gentleman ultimately got two things that made his diagnosis possible. John, we consulted dermatology and they got a skin biopsy. And the cell-free DNA also ultimately came back roughly the same day, roughly 7 days post gathering, and both were positive for blastomycoses. And so he was ultimately diagnosed with disseminated blastomycoses from both of these tests, and shortly was started on Ambisome for a 2-week course, and then transitioned to voriconazole. He had a number of complications and I think ultimately had a very prolonged medical course, but it was a fruitful diagnostic process, I think, for the whole medical team. Yeah, so.
Thank you, Millie, for the amazing case. How was your experience thinking about the case and waiting 7 days until you find the diagnosis while you figure it out throughout?
So I think the home institution waited 7 days. I only had to wait 5. But this has been a nice callback to the conversation I had when I admitted him to our institution. And it was similarly, I had a lovely fellow at the time and a lovely attending at the time who brought forward a lot of these questions about the serum testing. I had honestly had no exposure to serum Carious PCR testing. And although I love ID, I had lots of questions about all of the negative data that I had in a patient who was clearly harboring what was ultimately a life-threatening infectious disease. And so it was, I think this has been very interesting to watch people, I think about all of these tests that I have now ordered many, many times as an only 2-year-old doctor in my career, and have lots of experience. But it kind of goes to show we have a lot of power in a lot of our tests. But I think ultimately some of it requires a lot more thinking about, like, who is this patient and what kinds of things that he is at risk for. And that was, I think, one of the most helpful processes that we took to treat him or start treatment on him sooner than some of the tests came back. And so it's been nice to kind of remember that moment a little bit. Yeah.
Yeah, thank you for the reflection. We're proud of you. You're now a 3-year doctor because you're PGY3 right now.
True.
John, any reflections? What are like 2 or 3 teaching points that you would want like listeners to take away from this session?
Yeah, absolutely. Thank you so much, Millie. That was a wonderful case presentation, and appreciate all of the interaction on the chat as well. One of the things on reflection of my past year as a ID fellow is how humbling it can be when we have all these associations. Like Blasto, we think of being in a very particular region, or we think of, you know, Bartonella being like, oh, exposure to cat. And then in reality, in most of the cases where I've like diagnosed kind of these very specific diagnoses that have these associations, most patients are like, I've never encountered a cat in my life. And then you find out they have Bartonella. And so it's a very humbling process to be like, we are always thinking about these associations, but patients can deviate from that in any way, any which way they please. And so even though the patient is, you know, originally from Atlanta, which I don't commonly think of a very hot spot for for blasto, patients will surprise you. And so that was just one of my reflections from my past year as an ID fellow. But in terms of takeaway points, I think the two things I'd like to impress is, number one, doing our best to kind of figure out what syndrome we're trying to diagnose. So qualifying the syndrome as best as we can, saying that this is like subacute or acute shortness of breath in someone that has nodular consolidations on CT, as well as a new ulcerative lesion on their forehead. As much as we can, kind of defining that syndrome really helps to build your differential and to build your thought process as how you think through a patient. And so really clarifying the syndrome with as much quality and conciseness, I think, is something that's really helpful for all trainees and attendings to kind of help build their clinical reasoning. And then kind of second, more specific to ID, is like this pulmonary skin syndrome, really being kind of more characteristic for fungal etiologies versus mycobacterial, and to a lesser degree, some of those atypical bacterial pathogens like nocardia or actino. I think, again, kind of coupling with the first point, like as much as we can define the syndrome from an ID perspective on pulmonary skin syndromes, really thinking through your fungal etiologies, mycobacterial, and then some of those atypical bacterial pathogens.
Thank you, John. I also loved your teaching on the fungal culture. I wonder if they should like change the name to like histo blood culture and then people would have to think twice. Any reflections, Varun?
No, this was a fantastic case. Thank you, Millie, for sharing it with us. I echo sort of John's sort of feeling of being humbled by this patient population, like every time I round on the Transplant ID service. I think things that like you can't trust your scripts, the edges of your illness scripts become fuzzier, and the clear demarcations between what is supposed to present in an acute fashion versus a subacute fashion becomes less clean. You can't trust your diagnostics as well because patients with abnormal immune systems don't mount the same sort of antibody responses. They may have a lower burden of organism causing the same infection. And so you often are left with, tissue being the issue as the only way to make a diagnosis. And I think that was sort of demonstrated here. I think this is sort of another sort of fascinating case of something that we thought about. John listed these fungal pathogens very early on, but we oftentimes don't feel comfortable naming a specific pathogen because we've been sort of fooled by our intuition many times before.
Thank you both. Thank you all for joining. Hope you all have a wonderful day today, and go into infectious disease.
Thank you so much. Thank you, Yusuf. Thank you, Millie. Thank you, Varun.
Thanks, everyone.